Well, we wanted to do a team visit as long as you're okay with that, because I know there's lots of questions. We haven't had a good opportunity since we've gotten a lot more information kind of over the last week with the added pictures, everything like that. So, and we really haven't had the opportunity to sit down with you and talk about what our plan would be and why we would recommend that. And so I know this past week has probably been a lot of nerves and worry and trying to figure out what is the next steps. And that's kind of what we wanted to talk with you a little bit about today. Mallory's here just because I know from our last visit, it's always nice to have that added support that's not part of necessarily the treatment decision team per se, to have that extra added support as we go forward.
She's the fave.
Yeah, sorry guys. We're used to it. Not surprised.
Sorry guys, little mood lighter.
It's really so first and foremost, you know, I think we need to talk a little bit about kind of if this is what we think it is. So if this is relapsed ependymoma, we know from what it was the first time around that it was a more aggressive form of the ependymoma, but there were still good chances that we could keep it gone. What we know about these types of tumors that come back is that once it comes back once, kind of like we talked about on the phone, the chances of it coming back multiple times and becoming, like we talked about last time, harder and harder to treat with kind of each relapse is more likely. There are a couple things that make this relapse more manageable, and part of that is that they're smaller lesions. They're in that area where the surgery already was, so they haven't gone other places. And they're things that Dr. Katz, and he'll talk a little bit more about this, can surgically resect. What we know about ependymoma, similar to that very first, I'm going to ask you to remember way back when. What we know about ependymoma is surgery is the first and foremost best treatment for this. So if there is at all the option to go in, take these out completely, that is the absolute best option we have.
Okay.
In some cases, when it comes back, we talk about reirradiation. We talked with your radiation oncologist, and reirradiation right now is not the best option for you because, like we talked about, there is a lot of healthy tissue in that area.
Right.
And remember when they did the first radiation, they talk about not only do we radiate that surgical cavity, but we actually radiate a little further into that healthy tissue to ideally try and prevent any cells that we can't see on the MRI and that we can't see in the surgery, because we know we got a gross total the first time around. So that means like everything Dr. Katz could see, he got out, nothing we could see on the MRI.
Right.
So we were in a great spot. If we reirradiate at this point in time, it puts you at high risk for side effects in that area. And we know you had some side effects the first time around. By not reirradiating now, so not going back to radiation now, knowing that this does have the potential once it's come back once to come back again, it gives us that as an option in the future when you're farther out from the radiation and it's potentially at a safer point in time. There are lots of other kind of nuances. I know there's questions about clinical trials, and I'm going to address those as well. There's questions about chemotherapy. But since I know Dr. Katz is here to talk a little bit about the surgery, or a lot about the surgery, and that we know is kind of the key feature of this treatment, I'm going to let him talk about that first, and then we can talk a little bit more about what happens after. Does that sound okay?
Yeah.
Okay.
All right. So
First, we need to get you a new head thing.
yeah. That's not. I don't know. I'm not sure that's negotiable or not.
Oh,
He
Anyway.
hasn't lived here long enough yet.
I thought it was Browns, and I'm like, wait a minute.
So these are, for me, the important pictures that I want to talk about. So this was your first scan when we first met in August. This was 2 days later after we took it all out. And then this is the last one we had last Monday. And, importantly, we had, like we talked about, a gross total resection, everything was out. That means that everything that we could see is out. There's still obviously microscopic tumor cells that without us taking out a whole chunk of brain, and no one knows how much brain you have to take out for that. That's just kind of how it is.
Mhm.
The areas that are concerning are these two small areas, one right here and one right here,
Mhm.
and they're right on the like cavity border, but that's what we call this. I call it a cavity, like a post-op cavity, where I took that area out, and that's good and bad. I mean, obviously we don't want that. No one wants that. But these are in pretty superficial, meaning they're pretty easy to take out.
Mhm.
And I think that the risk of taking them out is pretty low. There's always risk of surgery, and bleeding, infection, all of those things, wound healing. Wound healing might be a little bit more of an issue the second time around after you've already had the treatment you've had. But I think that we can safely take these out with minimal risk.
Mhm.
With the caveat of surgical risks and then the wounds healing
Right.
risk. There's this one. I'm not too worried about this guy here. This one, there's a little bit more tissue around it, and I would be generous. I would try to take a little extra brain. If I had to choose between less brain and more brain, I would probably take a little bit more extra brain, in the sense of I don't want to leave anything. I really want to take every possible thing we can take out because I think that helps us in the long run.
Mhm.
But like we know, a ependymoma that comes back once, we're fighting an uphill battle. So I'd rather fight that battle with everything possible out than in.
When you say take out brain, what will that affect? 'Cause
Yeah, so that's a really good question. In this region, this is not going to affect your speech. I know that. Let me talk about what's not going to affect first. So your
Good, I
speech-
can still talk
speech
your
should be
ear off.
fine. For sure, your right-sided function of your right arm is fine. I even think your left side function is fine. I think this is a budding, maybe a sensory area where maybe her sensation might be. These are like worst case scenarios. I don't think we're gonna have any of these issues, honestly. And I think I'll get a plan and we'll take it all without taking like actively healthy normal brain.
Yeah.
But I'm gonna be more aggressive in taking as much as possible. So what could be there, like sensory changes. So difficulty with feeling on the left side arm more than leg, but hard to tell. And that's the biggest risk. There's a little risk maybe we're near an area of visual field. I don't think so. I think we're much higher than that. I think that's really the risk is a sensory issue, which is not a big deal.
My
Don't-
eyesight
In the grand scheme of
sucks.
things,
Don't need
in the
any of
grand
that.
scheme of things, if you had a talking problem, that's a big problem. If you had an understanding problem where you didn't understand words, that's a problem. If you have a problem making words, that's a problem. If you have a problem moving your arms and legs, that's a problem. If it was in that location, we had to do that. That's what we do. But that's not the case here. The case here is more of a sensory issue.
Okay.
that's
if
karma. Because she
if
hits me on mine because I don't have any feeling, and you hit me and you tease me, and that's.
I'll be like, can you feel this? Do you feel
I'm
it?
like, what?
And she'll be like, are you touching me? And I'm like,
So this
"Oh, I
is
guess
nothing.
That's fair.
This is fair.
If it happens, I guess it's fair.
So I think that's the major risk of this. The second other risk that I would be concerned about is a healing issue, just because we've already had radiation. But we'll get through that.
Mm-hmm.
I think that we would use the same incision, take that bone off, put that bone back on like we did last time. We can even bargain about less shaving of the hair this time if you want.
I like that. I like that a lot.
A few, in my evolution of being more on my own, doing my own surgeries, right? Like in training, you have to do what my boss tells me how much to shave. So some bosses like a lot of hair, some like little hair, and it's easier for me just to do a lot, right?
Mm-hmm.
But I've definitely minimized my hair shaves.
I like that.
So I will use that for you.
That sounds great.
Okay. So we'll give you a minimal hair shave, and so the plan would be, if you guys are okay with it, we were able to get some time on Thursday. I know it's a little fast. We'll have to get a few things good, like ready to go, if you guys are ready for that. But I think that I don't think there's any reason to wait from a tumor. There's always reasons to wait from a family standpoint, from whatever is going on, like that. But from my standpoint and our standpoint of trying to just see the tumor, take the tumor out, I think that Thursday would work well for us.
And what we're gonna do also is we'll get that final piece of information that we need, because Dr. Katz is gonna allow me to go first. So once you're under the anesthesia, and this we would recommend doing even if we waited on the surgery. We would do sedation like we did last time and get this, because no matter what we would do next, this is an important part of figuring out next steps, because if this fluid would be positive, if that lumbar puncture would be positive, it absolutely changes our recommendations. And we wouldn't just recommend surgery. We would try and be more aggressive and potentially even do full radiation to the full brain and spine.
Okay.
So the fluid changes things based on your pictures, based on what we know about this disease. It's less likely that this fluid is positive, especially since it wasn't positive the first time around. But anytime ependymoma comes back, we always do the lumbar puncture to double check. But the nice thing is we either do it as a sedation, or if we go to surgery, I do it right before the surgery. And so ideally, by the time you'd be out of the surgery, we'd even have some preliminary answers on that.
And the MRI showed nothing in the spine.
Correct. Right. So no what we call gross disease in the spine.
Yeah.
So this would be considered kind of gross disease. But like
It's gross.
Dr. Katz said, exactly.
That's great.
But like Dr. Katz said, sometimes there can be microscopic disease that we can only see when we look at the fluid under the microscope. And so that's why we always do a sample of it.
So if I were to have surgery on Thursday,
Mm-hmm.
when would I come in? Wednesday or Thursday morning? Or
Thursday morning.
okay, and
When can I
Okay.
get out is what he's
So
thinking.
that's a really good question. So I usually tell patients so between 3 to 7 days. If everything goes great, and I expect that it will go great, we're not doing a long surgery. You know, this is a lot less of what we did than the last time. And I don't remember how long it took you to go home last time. We had some
A week.
I remember we had some Keprowoozy issues. So
we did.
But it wasn't it wasn't like 7 days, I don't think.
It was a week.
It was a week exactly.
A week and a day.
So I think that we could, if you're out by Monday, I would love that. I think that's reasonable.
Okay.
Maybe Sunday, maybe Tuesday, right? Just seeing how everything goes.
Yeah.
Because I know there's the question of school and things like that.
Yeah.
too.
Martin Luther King Day. She got another day off. What do you think about if she did get out, even if she got out a week after,
Yeah.
about going to school?
So I think traveling to North Carolina, correct? That's what we're talking about. So, I think that if everything goes fine, goes well, goes perfect, I don't have an issue with it going. I'm trying to see what's the least I would want you here. I mean, they have neurosurgeons there, right? They're comfortable taking care of stuff. I think let me think about that. I think that for sure after the 2-week visit, if things are going well, I think that would be okay. And maybe I could even be, convinced to let you go earlier.
Well, would I so as of right now, would I be doing chemo? Like I just do nothing and we just wait for it to
So,
come back.
unfortunately. And I know that sounds really hard to hear, but there have been a lot of studies that have looked at chemotherapy in relapsed ependymoma. There are some age groups that we know have a better chance of benefiting from it, and normally it's the kids that are less than 3 years of age with the tumors that happen remember we talked about the 2 spots, you can have the tumor kind of up here and then back here. It's normally the kids that are less than 3 years of age with the tumors that are down lower or the back of their head. And we know that even then, when chemotherapy does work, it doesn't work in a lot of patients. They have tried tons and tons of different chemotherapy in relapsed ependymoma, and none have really shown a lot of benefit, especially in local recurrence. So if there's fluid positive, then it might be an option. But right in local recurrence, it's still surgery is the first and foremost, and plus or minus radiation if it's safe. So as of right now, we would be doing really close interval follow-ups of about every 2 to 3 month scans after the surgery.
This is a very drastic question.
Yeah.
If it just keeps coming back, is it gonna kill me?
So there is a small subset of patients that with multiple resections, multiple different types of treatment, that we can keep it gone and keep it gone for a long time. That does require multiple different types of treatment. there is a much larger subset of patients that eventually, after multiple recurrences, it becomes so hard to treat that it does end up at death.
So like,
We're not there yet though. There's
Right.
still,
No,
this is,
we're-
and this is, ependymoma tends to be what we call, it becomes, when it recurs, it becomes almost like what we call a chronic disease, in the fact that it requires lots of observation, lots of different re-resections, lots of different kind of types of treatment over a prolonged period of time. But there is that possibility, but we do everything we can to prevent that.
I can get hit by a car tomorrow. I can have another stroke. Baby, we're just living life.
And Molly, what I will tell you is that, like, we've been blunt with you this entire time, and like, I'm obviously not lying to you right now. If we ever get to the point where we think treatment is what we would consider futile, or where we think it's going to cause more harm than benefit, and that's why right now I don't even recommend chemotherapy, because I think the side effects would be more harm than what it could potentially provide. We'll let you know. But we're not there right now, and this is still something that we can treat and give a good amount of time. And even potentially there is that small subset of patients where when we re-resect it, it doesn't come back. Or even if it does come back a second time, if we re-resect it and are able to re-irradiate at that point in time, that it doesn't come back. So there's still always that possibility. It's just every time it comes back, kind of like this is a different conversation than we had the first time around. Every time it comes back, the chances of it coming back again become higher.
And to reiterate, if myself or Dr. Wright felt that we were doing something that was going to change, if we thought that the time of this disease was at a certain point, and we had that point in our mind that it was some time, and us doing stuff to you was going to decrease that time that you were going to have a great life or whatever, we would not jump into that. Like we had that discussion 5-10 minutes ago, and we're nowhere near that. Not even close. This is still, we're still fighting, and we're still going to hopefully win this, right?
Yeah.
That's our thought process. If it comes to the point where it's obvious to me, to everyone in here, to you guys, that we're fighting an uphill battle, and we want to not be in the hospital for a week of that time or whatever it is, that's totally reasonable, totally fine. But I don't believe we're at that point at all.
Correct.
And we take that seriously. That
Yeah.
if we thought that you would be better off just going to college and doing your thing and not having to worry about this few weeks, we would tell you that up front completely. But we're not. I don't think we're anywhere near that.
And regardless, we're always going to support what you guys want. So whatever that fight looks like for you, whether it's fight for I want to be in school, or fight for I want to be more comfortable, or whether it's fight for I want to try any new drug out there that I can, we're going to help support you in that, but we're going to be honest with you about realistic expectations.
So we took the pathology, the molecular pathology, and I did
Yes.
send it to Duke, and I sent it to
Perfect.
St. Duke's.
Good.
And Duke said that their protocol is not waiting 2 years between radiation, but doing a lower dose radiation within a year.
Okay,
And they said that they felt that they would like to speak to Dr. Mansour
sure.
about that if she decides to have it here, just
Yeah.
to see what there is. There's another doctor who said, have you tried mistletoe? I'm like, other than it being a positive name to it, I have no idea what it is.
Yes. So there's lots of different, so this kind of brings us to that second part. So I think that from a radiation perspective, I know the literature, I know that some do radiate prior. I always defer to my radiation oncologist when it comes to safety, but I know Dr. Mansour is really good about, I mean, obviously he collaborates with all of us and everything like that, so I know he's really good about collaboration, and so I'm sure he'd be willing to talk with the Duke radiation oncologist. So I think we can absolutely help facilitate that. We'll let his assistant know that kind of coordinates all of that stuff for him. When it comes to, so that will be like a radiation oncology discussion. I know you'd ask about a couple different types of radiation. I think some of it also depends on the type of radiation you got up front and the doses you got up front. So sometimes that's where Dr. Manser's hesitations may lie.
She said flashes off the table.
Yeah,
Flashes off the table,
Yeah.
some of the other things off the table, because
Correct.
after looking at the molecular makeup, it just wouldn't do her any good.
correct, exactly. The Relay fusion, like we talked about that first time around, is a very common thing that we find in kids your age with this anaplastic ependymoma. It's one of the two most common things we find in ependymoma. We do know that, and that's why our numbers that we told you kind of up front were a little bit different, because we do know that these types of tumors, the Relay, have a little bit higher chance of coming back than the other type. And so that's why initially when you asked about numbers and recurrence and things like that, that's why the numbers were what they were.
Mm-hmm.
The other thing I wanted to talk to you guys about today is if Dr. Katz goes in on Thursday, and that's the plan, and he takes this out, not only do we want to look at it under the microscope again, I want to send the molecular testing again. So I actually have the forms so that would be all ready to go. And the reason is because I don't expect that Relay, if this is ependymoma, I don't expect that Relay to have gone away. But sometimes after radiation, it can cause changes in the tumor that may give us a benefit of something that we can target with therapy. The first time around, unfortunately, that Relay fusion is not something you can target with like a specific medicine.
Mhm.
But if there are other changes in the tumor that we see, that can change our options from a therapy perspective as well. And so some of those targeted agents even are things you could potentially take by mouth and stuff like that. So that does change things a bit. So
And to jump on that, I've had patients that we have done re-resections of
Mhm.
ependymoma, and the molecular studies are different on the second
Correct.
time around. And so, that's a mutation, we think, and that's meaning like we talked about in this virus that's going on, right? There's
Mhm.
different types of mutations, different spike proteins or whatever on that virus. So there's different avenues. So my point, get back to my real point, is that there's mutations going on as this is dividing, and something can change. So just because what we said last year or two, whatever we did a year and a half ago, of what it was then, things have been changing and progressing, and it could be different. It may be different, probably is different, and just the plan for that tumor is totally different than the plan for this tumor. You have to think of it as two different, not different, but an evolving tumor. Correct me if I'm wrong.
So yes and no. And the only reason I say that is because normally what we find is that it's the same broad category of tumor, like it's not drastically changing.
Right.
So we still expect to find an ependymoma.
Yeah.
Because I would say that a majority, there's a very, very small chance, like we talked about, this close to radiation. But what does happen is, as Dr. Katz said, as the tumor divides, the main drivers to begin with, like that Relay fusion, tend to stay present. Those big, they've done tons of studies where they've re-resected tumors and looked at the beginning mutations versus the second mutations, and almost always those big kind of driver mutations like that Relay are still present. But what we find is that as it divides, as we add radiation, as it changes, we get more mutations. And those added mutations may be things that we know we can target with certain types of chemotherapy, certain types of what we call targeted therapies. Targeted therapies are therapies that are very specific to mutational changes in the tumor. Right now, we unfortunately don't have one for Relay, but there are lots of other changes in these tumors that we can see that we do have targeted therapy for.
So right now, the plan is surgery. You really, like you said last time, we can't make a decision on radiation or chemo until you see pathology.
Correct.
It just goes back to the same.
Yep.
Same ballgame. We
Ballgame.
find out exactly what it is. We can't tell from the MRI. It's most likely recurrent tumor. There's a very, very tiny chance that it's not. But we still have to send it to the pathologist. They look at it on the microscope for a week or two, telling us exactly what it is. And in that time where we're healing, we're waiting for that answer so that then we can take the next step if it is something that we need to do.
The question there is when we were at the hospital getting ready to get discharged, we were waiting for the molecular report to come back, and it was going to be 3 weeks. She got sick that morning, and that's why it was rushed, and she got it right away. Can we rush that sucker? Or, I get it, we're in a line.
So like we talked about, it's the different types of testing that we do may be a little bit faster this time around, because of the fact that we in some ways know what we're initially looking for, so they can do some earlier stains and stuff like that. The actual staining of the tissue takes time. They do specific what's called immunochemistry stains on it, looking for specific markers to confirm that this is ependymoma. All of that takes a certain amount of time. So it's not like you're behind 6 other tumors that we're waiting to get the diagnosis on first. It's literally that it takes time to get the information we need. The molecular testing, it takes time because they literally take the tumor, they extract out the DNA of the tumor, they then have to replicate the DNA of the tumor, and then they have to send it kind of through processing so that the processing can actually tell us what the changes are. So it's not that when we give you these kind of 7 to 10 days, it's not that you're behind other people or that there's something that we can rush. As soon as we have answers, like last time, if we have them, we'll give them to you. But it's something that takes time, and it has to do with the process of how we get the answers, not that it's waiting in a line.
And when I say this, 10 days or 2 weeks, that is a way of me telling you guys, just relax for 2 weeks. It could take that long, but if it comes back in 4 days, we'll tell you that. We don't hold it for 2. We're like, oh, we told them 2 weeks. I think we're stupid if we tell them we took fast, right? Like, so I tell everyone 10 to 2 weeks, 10 days to 14 days, because sometimes families need they won't be able to live their life every hour knowing that it might come back. And if I tell them 2 weeks, that's a time frame for them to mark on their calendar.
The biggest worry I have with Molly as her mom is that she wants to know. She needs to know the stuff, and
I can promise you that you guys will know within the hour that we know.
Yes.
There's no, unless it's Saturday night at 2 a.m, we'll call you on Sunday morning.
when it was the whole, this is happening, it was, I just got my hair long enough to pin it, and I just want to know that I'm doing something.
Yeah.
Because when we stopped coming here for the day rehab, and when we stopped actively treating, is when that November, when radiation was done, that was the struggle. It wasn't during. She can do the hard work. It was when it felt like we're doing nothing, and that's what I'm worried about.
Yeah, that's why I'm worried about not having any treatment, because like if I just know it's gonna come back, that's gonna be like very difficult for me to live my life.
Yeah, so I completely understand where you're coming from. We take an oath as physicians to do no harm. And so every time we talk about treatment, we're talking about risks and benefits. So when we make these recommendations, we're trying to make the recommendations that are going to provide you the best kind of outcomes with the least amount of risk. That's why chemotherapy is not a benign treatment. There are lots of side effects, not only short term when you're getting it, but also long term. And so that's why if there's not enough data to really say that chemotherapy is going to provide you a benefit, because when they did the comparison studies, they showed no difference between those that got chemotherapy and those that didn't. And so if that's the case, exposing you to those risks would not be my recommendation. The same comes from, and that's why I think that's where Dr. Manser's sitting too. But I'm sure if there's a way that he could give it safely and do something, that would be something he'd be open to. So I don't want to speak for him from that perspective, but that's why I take his opinion very with a lot of weight, because if he tells me it's not safe and he's really worried about the side effects you're gonna get, that to me is very important as well. And that kind of brings me to clinical trials. So clinical trials are options for when there's almost always a clinical trial for when something recurs. Clinical trials come in a wide variety of forms though. And so I think it's really important, if clinical trials are something you're considering, that you know the different types of clinical trials. So clinical trials are staged in kind of 3 different groups. So there's phase 1, phase 2, and phase 3. And then there's kind of some that bridge in between those 2 phases. Phase 3 is what we think about for like the classic clinical trial. You're normally comparing a new drug to an old drug, or a new drug to a placebo. In tumors, we normally don't compare to placebo because we think that's cruel and not fair. But so it's normally a new drug to an old drug, or a new drug added on to a standard treatment. So for something like this, potentially surgery plus a new drug. In phase 3 clinical trials, You're comparing to see if you can extend kind of how long you live or extend the time to when this would potentially come back compared to those that don't receive that treatment. If there was a phase 3 clinical trial right now, I think that would be a good option, but there aren't any phase 3 clinical trials right now for your type of tumor. That I could see on clinicaltrials.gov, which has all of the clinical trials kind of across the country and the world. There are some what we call earlier phase clinical trials, which would be phase 1 and phase 2. Phase 2 starts to look at what we call early efficacy. So it starts to just look at, okay, now we've given a medicine, we know the dose we're giving it at. Short term, is there any improvement? Phase 1 is purely looking at what dose is safe to give. Now we give it in these what we call high risk populations because we know that if there's anything that we give that could potentially provide anyone benefit, that would be great. But it's not looking at, phase 1 trials are not looking at efficacy, so they're not looking at overall survival. They're not looking at improving time to progression. They're purely looking at what doses are safe to take. And right now, the only clinical trials that are out there for recurrent anaplastic ependymoma that I could find, and that includes the St. Jude SJ Dawn, and the there's a trial at I believe it's Sloan Kettering Vorizumab. Those are both trials that are in phase 1, so they're purely looking at kind of dose finding. I like clinical trials. I think they're amazing. I think they're how we move science forward, and I think that for some patients, they provide a lot of benefit. I think that phase 1 clinical trials, I tend to reserve for when we're having those conversations of we're starting to fight that uphill battle, and we need to kind of throw the kitchen sink at this because there aren't standard ways of potentially treating this. Or it's come back and it's too big and Dr. Katz says that surgery is too dangerous. I can go in, I can take some of it out, but I can't take all of it out. Or we've exhausted reirradiation and now we're sitting there again. And I know these are hard to think of kind of because it's so hard to hear me say that if we do nothing, the likelihood of it coming back is much higher. But at the same point in time, sometimes doing something causes more harm or prevents us from having options down